Welcome to today's deep dive. We are taking a massive stack of sources today, like historical medical records, landmark multi-decade clinical trial data, and some incredibly cutting-edge biochemical research.
Yeah, it's a really diverse spec, and we were zeroing in on one central question, like why and how does diabetes systematically damage the body's organs over time?
Right, because the mission today is to move past that simple everyday advice you hear, like, oh, watch your blood sugar. We want to uncover the fascinating and honestly counterintuitive cellular mechanisms that dictate exactly how chronic high glucose physically alters our blood vessels and our nerves.
Exactly. We hear the warnings about high blood sugar all the time, right? But we rarely examine the actual mechanics of what that sugar is doing in the
Yes.
dark.
So, okay, let's unpack this. Because what is happening at a microscopic level is going to completely change how you view human biology. To visualize that, think about how we usually picture bodily injury, right?
Sure. Yeah.
We tend to imagine something dramatic and immediate, like a broken bone or a deep cut. You can see the damage, you can point to it, and your body immediately starts trying to fix it. It's like taking a sledgehammer to drywall.
Right. The injury is visible, it is localized, and the cause and effect is usually pretty undeniable to anyone looking at it.
But the cellular mechanisms we are looking at today operate like a totally different kind of damage, like the kind that works more like a slow, silent leak behind that drywall.
Yeah, that's a great way to put it.
You don't see it, you don't feel it, but month after month, year after year, it is structurally rotting the house from the inside out until one day you wake up and the ceiling just caves in.
And that relentless silent erosion is the absolute definition of diabetic complications. Clinically, well, the medical field has traditionally split this damage into two distinct buckets.
Okay, two buckets. What are we looking at?
First, we have microvascular complications. This refers to the degradation of the body's tiniest blood vessels, the capillaries, which manifests as, retinopathy in the eyes, nephropathy in the kidneys, and neuropathy in the nerves.
Right. So if the first bucket is microvascular, dealing with the tiny capillaries, it logically follows that the second bucket is macrovascular complications, dealing with the major clumping, like the larger arteries.
Yeah, the cardiovascular system primarily. This is the accelerated, widespread damage that leads to heart attacks, strokes, and peripheral artery disease.
Although the sources mention that this two-bucket system might be a bit outdated now.
Yeah, modern researchers are actively debating whether this is a false binary. A growing consensus actually prefers to view the entire process as a single spectrum of hyperglycemic vascular injury.
Because it's all essentially the same problem, right?
Yeah, exactly. The root cellular cause driving the damage in the eyes is essentially the same as the one driving the damage in the heart. But to really grasp how the medical community figured out these complex cellular pathways, we have to look back at a time when these specific complications were virtually non-existent.
Which, I mean, sounds incredibly strange to a modern listener. We associate diabetes entirely with these long-term complications. How could they not exist?
Well, before the year 1921, a diagnosis of what we now classify as type 1 diabetes was essentially a death sentence. And it was a fast one, usually measured in mere months, maybe a year or two for an adult.
Wow, just months.
Yeah. Without insulin, the body cannot utilize glucose for energy, so it just begins burning fat at an uncontrolled rate. Patients die of diabetic ketoacidosis, a lethal shift in blood acidity, and starvation-level wasting. They simply did not live long enough for this slow, silent vascular damage to accumulate.
Oh, I see. So the sledgehammer got them before the water damage even had a chance to start rotting the wood.
Precisely. But that changes entirely in January 1922. Frederick Banting and Charles Best, working out of the University of Toronto, discovered how to extract and synthesize insulin.
Right, and they gave it to that young boy, right? Leonard Thompson.
Yes, a 14-year-old boy who was slipping into a coma. And the results were immediate and miraculous. In a matter of days, insulin turned a rapidly fatal acute disease into a survivable chronic one.
It's just an incredible historical irony. It's almost like inventing the modern seatbelt,
How do you mean?
Well, you save people from flying through the windshield and dying instantly on impact, but because they survived the crash, you suddenly have a whole new medical category of whiplash to deal with. The cure unmasked a long-term complication no one even knew was there.
That is exactly what happened. The clinical landscape transformed within a single generation. By the 1930s and 40s, patients were living 10, 20, even 30 years past their diagnosis. Consequently, doctors started seeing pathologies they had never documented before.
Things like blindness and kidney failure.
Yeah, patients were gradually losing their sight, going into unexplained kidney failure and losing all sensation in their lower extremities.
Which brings our sources to Elliot P. Joslin, the founder of the Joslin Diabetes Center.
He was a true pioneer, mostly because he had started keeping meticulous, highly detailed long-term records of his diabetic patients even before insulin was discovered.
So he had all the baseline data to compare it to.
Exactly. Thanks to that data, his clinic in Boston became the epicenter where these new chronic complications were systematically tracked. Joslin developed a very strong intuition. He became a vocal advocate for the idea that keeping a patient's blood sugar tightly controlled, as close to non-diabetic levels as possible, would slow down or prevent this systemic organ damage.
So he publishes these observations, he advocates for tight control, but going from "I have an educated hunch that sugar causes this" to having undeniable bulletproof clinical proof takes time, right?
It took 6 decades.
Wait, really?
Huh.
6 decades?
Yeah, treating patients based largely on that intuitive logic. The medical community demanded hard data, and they finally got it through a landmark study called the Diabetes Control and Complications Trial, the DCCT, which ran from 1983 to 1993.
Okay, so what exactly did they do in this trial?
Researchers took 1,441 patients with type 1 diabetes and randomized them into 2 groups. One received intensive insulin therapy, and the other received the conventional therapy of the era.
And the goal for the intensive group was keeping their HbA1c, which, for you listening, is a blood test that measures a roughly 3-month average of your blood sugar, around 7%.
Right.
Meanwhile, the conventional therapy group hovered around a much higher 9%.
Right. And the medical establishment was waiting to see if that 2-point difference actually mattered. The results published in 1993 were staggering.
Let's hear the numbers.
The intensive control group saw their risk of developing retinopathy drop by roughly 76%.
Wow.
Nephropathy risk dropped by 50%, and neuropathy by 60%. It was definitive proof that glucose levels directly drive the damage.
Those percentages are huge. They completely validate Joslin's hunch. And I know the sources emphasize this wasn't just true for type 1 diabetes.
Right. A subsequent trial in 1998, the UKPDS, demonstrated similar outcomes for type 2 diabetes. That trial was remarkable because it established a mathematical dose-response curve.
A dose-response curve, meaning they could predict the benefit.
Yeah, they found that for every single 1 percentage point drop in a patient's HbA1c, their risk of microvascular complications dropped by about 37%.
That is wild. Though there is a massive caveat in the sources regarding the timeline of these 2 types of diabetes that we definitely have to clarify.
Oh, absolutely.
With type 1, the patient's immune system attacks their pancreas, so insulin production stops entirely. The onset is sudden, meaning they start with a relatively clean vascular slate on the very day of diagnosis.
Right. The clock on the complications essentially starts ticking at diagnosis. But type 2 diabetes follows a completely different trajectory.
Right.
People with type 2 often experience years, sometimes a decade or more, of undiagnosed insulin resistance. Their blood sugar is gradually creeping up, slowly damaging tissues long before it crosses the official diagnostic threshold for diabetes.
Meaning the macrovascular damage, like the stiffening of the big arteries, can be well underway the exact moment a doctor says you have type 2 diabetes. The water has been leaking behind the drywall for years before the stain finally shows up on the paint.
Exactly. The clinical reality is that many type 2 patients present with cardiovascular disease at the exact same time they receive their diabetes diagnosis.
Okay, but let's pause here and look at this logically. If the clinical trials in the 90s proved without a shadow of a doubt that high blood sugar causes 76% more eye damage, we still haven't answered our main question. Like, how is the sugar doing it?
Right.
If blood circulates everywhere in the body, the excess sugar is circulating everywhere. Why isn't every single organ breaking down at the exact same rate? Why the eyes, kidneys, and nerves, but not the lungs or your bicep muscles?
It's a great question. Epidemiology can show that high sugar correlates with kidney failure, but it takes biochemistry to explain the physical mechanism. And the answer to your question is the central aha insight of this deep dive.
Let's get into it.
In 2001, a researcher named Michael Brownlee presented a unifying theory that solved the mystery. It all comes down to the doorways on the surface of our cells.
The glucose transporters.
Exactly. The first step in Brownlee's theory is recognizing that glucose, when it's highly concentrated and left floating in the bloodstream, is fundamentally a corrosive molecule. It is fuel meant to be burned inside a cell, not left lingering in the blood.
Okay.
The second step is realizing that not all of your cells have the same defensive capabilities against this corrosive fuel.
Okay, let's unpack these cellular doorways. Most of the body's cells, like our muscle and fat cells, use a specific type of door to let glucose in, known as GLUT4. And the critical detail about GLUT4 is that it is insulin dependent, right?
Right? Insulin is the physical key that turns the lock. If blood sugar spikes dangerously high, these cells can essentially hunker down. They downregulate GLUT4, refusing to let the toxic excess of glucose inside, which protects their internal machinery.
The mechanics line up perfectly with a nightclub analogy. Like, your muscle cells are an exclusive club, and GLUT4 is the bouncer. When the bloodstream gets too crowded with glucose, the bouncer just locks the doors. The club stays safe, even if it's total chaos out on the street.
That's spot on. But the specific cells that get destroyed by diabetic complications, the parasites in your retinal capillaries, the mesangial filtering cells in your kidneys, and your peripheral nerve cells, they don't use that bouncer.
Oh.
Yeah, they rely on completely different insulin-independent transporters, specifically GLUT1 and GLUT3.
Which means they can't lock the doors.
Right. They are structurally designed to take in glucose no matter what, which makes sense evolutionarily, as your brain and nerves need a constant energy supply.
But in the context of diabetes, it means they are like a subway station with broken turnstiles. When the 5 p.m. rush hour crowd of glucose shows up in the bloodstream, they cannot lock the doors. The sugar just floods right in, completely unchecked, and trashes the station.
Exactly. The influx of glucose is in direct, unregulated proportion to whatever the blood sugar level is outside. If a patient's blood sugar is triple what it should be, the glucose concentration inside those specific eye, kidney, and nerve cells triples. They are physically defenseless.
That is terrifying.
It isn't that your retinas are just unlucky, it's that they literally lack the biological bouncer to stop the flood.
That completely reframes how I look at a high sugar spike. It's not just a temporary energy fluctuation. It is a structural vulnerability for those specific organs. So the subway station is flooded. The glucose is inside. What does it actually do to break the cell from the inside out?
Well, this is step 3 of the unifying theory. Brownlee showed that this massive flood of glucose completely overwhelms the cell's mitochondria.
The powerhouse of the cell, the energy generators.
Right. When the mitochondria get overloaded with way too much fuel, the electron transport chain inside them essentially backs up. They start choking on the glucose. And as a byproduct, they spew out massive amounts of reactive oxygen species, or ROS.
Which is really bad.
It is. It creates severe oxidative stress inside the cell. That stress acts as a master switch, simultaneously triggering 4 completely distinct, highly destructive biochemical pathways.
The 4 horsemen of cellular damage.
Okay.
Let's walk through exactly how they tear the cell apart. Pathway number 1 is the polyol pathway.
Right.
So when the cell realizes it is drowning in excess glucose, it panics and shunts the sugar through an enzyme called aldose reductase, which converts the glucose into a different compound called sorbitol.
Exactly. And the immediate problem with sorbitol is that it cannot easily cross cell membranes to escape. It just gets trapped inside.
Oh, man.
And because sorbitol is highly osmotic, it acts like a sponge, drawing water into the cell. The cell begins to physically swell up.
Like a water balloon.
Exactly. And simultaneously, the process of making that sorbitol severely depletes the cell's antioxidant reserves, leaving it even more vulnerable to that initial oxidative stress. This specific swelling pathway is a major driver of diabetic cataracts and early nerve damage.
Okay, so we have swelling and antioxidant depletion. That's horseman number 1. Horseman number 2 involves AGs.
Yes, advanced glycation end products. This is a process of non-enzymatic glycation. Basically, the excess glucose molecules physically crash into proteins and lipids inside and outside the cell, like the flexible collagen in your blood vessel walls, and chemically bond to them.
Just crashing and sticking.
Yeah. It is essentially a chemical caramelization occurring at body temperature.
So the sugar is quite literally gumming up the structural works of the blood vessel.
Right. It creates abnormal cross-links between proteins, turning healthy elastic blood vessels into stiff, brittle tubes. And furthermore, these AGEs bind to a specific receptor on the surface of other cells, appropriately named RAGE. Yes. And when RAGE is activated, it sets off a chronic systemic alarm bell, flooding the surrounding tissue with inflammatory signals.
Yikes. So if we have osmotic swelling from sorbitol and stiffening and inflammation from AGEs, I mean, that sounds like a mechanical disaster for the capillaries. But does it also affect the way the blood actually flows?
It absolutely does. And that brings us to the third pathway, protein kinase C, or PKC, activation.
Okay, what does PKC do?
Well, the initial oxidative stress on the mitochondria flips this enzyme into overdrive. PKC alters blood vessel permeability, essentially making the biological pipes leaky. Crucially, it also drives the rapid growth of abnormal, incredibly fragile new blood vessels.
Wait, it grows new vessels?
Yeah, and this is the hallmark of advanced diabetic retinopathy. The eye's tissue is starving for oxygen because the original vessels are damaged, so it desperately tries to grow new ones. But the PKC pathway ensures these new vessels are so weak, they just rupture and bleed directly into the retina, causing blindness.
It's just a devastating cascade. And the fourth pathway.
The hexosamine pathway. This one is insidious because it reaches directly into the cell's command center, the nucleus, and alters gene expression. It switches on genes that synthesize proteins that make the blood vessels even thicker and much more prone to clotting, further restricting blood flow.
Okay, so here is the physical manifestation of all four of these horsemen working together over the years, which brings us to step 4 of the pathophysiology. Let's look at the kidneys. We mentioned they have those broken turnstiles.
Right.
The kidney is essentially a microscopic sieve that filters toxins out of the blood while keeping valuable proteins in. But when these 4 pathways swell, stiffen, and inflame those delicate filtering cells, the mesangial cells, the holes in the sieve physically widen.
The biological filter just degrades.
And proteins that should stay in your blood, like albumin, start leaking through the wider holes into your urine. This is called microalbuminuria, and it is often the very first clinical warning sign a doctor sees that the kidneys are sustaining structural damage.
Yeah, and the same structural degradation happens in the nervous system. The nerve fiber death begins at the extremities, the tips of the toes and fingers, and slowly creeps inward.
That's the numbness.
Right, it creates a classic stocking and glove distribution of numbness. A critical distinction here is that the nerve damage isn't solely because the stiffened blood vessels are starving the nerve of oxygen, though ischemia plays a big role.
Right.
Is a dual threat. The nerve cells themselves are suffering from direct metabolic toxicity because they took in way too much glucose.
Okay, wait, I have to ask. If we know these exact 4 biochemical pathways, if researchers have them mapped out perfectly on a whiteboard, sorbitol, AGEs, PKC, and hexosamine, why hasn't a pharmaceutical company just invented a pill to block them? Just give a patient an anti-polio pill, block the aldose reductase enzyme, and the problem is solved, right?
The entire pharmaceutical industry had the exact same thought in the 1980s and 90s. They threw billions of dollars at it. It seemed like the perfect textbook case of translating first principles biochemistry into a wonder drug.
But we don't have those drugs today. What went wrong?
Human biology is incredibly messy. Let's take the polyol pathway you just mentioned. Companies developed a whole class of drugs called aldose reductase inhibitors, like one named sorbinol, designed to stop the cell from making sorbitol.
Okay.
But when they moved from the whiteboard to human clinical trials, the drugs either outright failed to prevent the complications or they triggered unacceptable toxic side effects in the liver.
Oh, wow. Did they try to block the other pathways?
They did. They designed a high-profile drug called roboxystorin specifically to block the PKC pathway. It showed some early promise for treating retinopathy, but it simply did not hold up to long-term efficacy standards. It was abandoned before it even secured FDA approval.
That's so frustrating.
It's a very sobering lesson for the medical community. Just because a target is mechanistically elegant in a petri dish does not guarantee you can safely jam a chemical wedge into it in a living human body without breaking some other vital system.
So, after all that brilliant biochemical discovery, we are largely back to Joslyn's original rule from the 1920s. Just keep the blood sugar as close to normal as possible. Which, on the surface, sounds like straightforward advice, right? If high sugar is bad, lower must always be safer.
Well, that assumption leads us directly to the biggest shock to the field of diabetes care in modern history, the ACCORD trial, published in 2008.
Right, this study completely upended the standard of care.
It really did. Researchers looked at the DCCT data from the 90s, which proved that lowering HbA1c to 7% was highly protective. They hypothesized, logically enough, that pushing it even further would yield even better results.
Makes sense.
So they enrolled patients with long-standing type 2 diabetes who already had high cardiovascular risk, and they treated them aggressively with multiple medications to force their blood sugar down to near non-diabetic levels, under 6% HbA1c.
Following the logic that if a 7 is good, a 6 must be better.
But the trial coordinators actually had to halt the intensive control arm of the study years earlier than planned.
Wait, why?
Because the intensive group was dying at a significantly higher rate than the standard control group.
Treating their numbers better was actively killing them. That must have been terrifying for doctors to realize.
It genuinely destabilized the entire medical community. What they discovered was that aggressively pushing blood sugar down in patients who already have long-standing diabetes and compromised, stiffened blood vessels induces severe episodes of hypoglycemia, dangerously low blood sugar.
And low blood sugar causes a whole other set of problems.
Exactly. When blood sugar drops, the body panics and releases adrenaline to free up emergency energy. That adrenaline spike causes a rapid heartbeat and spikes blood pressure. In a patient with fragile, already damaged coronary arteries, that sudden stress can easily trigger a fatal arrhythmia or a heart attack.
So lower is always safer is actually a deadly misconception. It's totally dependent on the state of the patient's existing vascular damage.
Exactly. It forced a total rewrite of medical guidelines. Today, the absolute standard of care is that glycemic targets must be strictly individualized. A healthy 30-year-old newly diagnosed with type 1 diabetes is given a very different, much tighter target than a 75-year-old who has a 20-year history of type 2 and a previous heart attack.
All right, the context of the patient changes the treatment. And speaking of external context, our sources reveal a really surprising nuance about that second destructive pathway we discussed, the AGEs, the chemical caramelization of proteins.
Yeah, this is fascinating.
We naturally assume this is strictly an internal problem driven by our own elevated blood sugar.
Well, the internal production is a major factor, but it turns out we can also consume them directly.
Dietary AGEs, this completely shifts the paradigm of how we view cooking.
It really does. When you prepare foods using very high, dry heat, think grilling a steak over a flame, roasting or deep frying, the intense heat accelerates a chemical reaction between the sugars and proteins in the food itself. It generates high levels of dietary AGEs right there in the meal.
So what's happening in the pan?
Yeah. And when you eat that charred or fried food, your body absorbs a significant portion of those preformed AGEs into your bloodstream.
So even if your internal blood sugar is perfectly controlled, if your diet is packed with charred, deep-fried foods, you are manually loading your bloodstream with the exact same inflammatory, vessel-stiffening compounds that uncontrolled diabetes creates naturally.
Right. It adds directly to your body's total AGE burden, completely independent of your daily glucose readings. It highlights that managing metabolic health requires looking at both internal control and external inputs.
So when we take all of this, the broken turnstiles, the 4 biochemical horsemen, the failing kidney filters, the dying nerves, and the stiffened arteries, what does this actually look like when it cascades in a real human being? Because the sources provide this incredibly sobering, concrete case study, the diabetic foot.
Yeah, it is the most tragic, perfect example of how these micro and macro complications compound upon one another.
Walk us through it.
The cascade usually begins with a microvascular damage, the neuropathy, because the longest nerves in the body degrade first. Dying from that combination of ischemia and metabolic toxicity, the patient slowly loses protective pain sensation in their feet.
The stocking and glove numbness. So you step on a tiny pebble in your shoe, or you develop an ingrown toenail, and your nervous system simply does not send the pain signal to your brain.
Exactly. Normally, pain is a protective mechanism. You'd stop walking, take off your shoe, and address the pebble. But here, the patient continues walking on it all day. The friction breaks the skin.
And then what?
That leads to step 2, peripheral artery disease. The macrovascular damage has been quietly clogging and stiffening the major arteries in the leg.
So the tissue surrounding the tiny cut is starving for the oxygen and nutrients it desperately needs to undergo normal cellular repair.
Right, the healing process is stalled.
Yeah.
And then step 3 enters the equation. Chronically elevated glucose severely impairs the function of immune cells. Yeah. The tiny cut inevitably gets infected, the local immune cells are too sluggish to fight off the bacteria, and the clogged arteries prevent the body from rushing reinforcements to the site.
All 3 systems fail simultaneously. That tiny, unfelt pebble silently progresses into a non-healing ulcer, which progresses to tissue necrosis or gangrene. And without aggressive medical intervention, it often ends in amputation.
Exactly. This cascade is precisely why a doctor will insist on taking off a patient's socks for a thorough foot exam, or dilating their eyes to look at the retinas, even if the patient feels completely fine. By the time a patient actually feels the damage, those pathways have been silently running for years.
And this brings us to why this deep dive matters so much for all of us today. We aren't just exploring abstract textbook biochemistry. Type 2 diabetes is rising at a staggering rate globally, and structurally, the disease is shifting into younger adults and even adolescents.
Which means the chronic hyperglycemia has decades of additional time to erode vessels and nerves. It is currently a leading driver of global blindness, end-stage renal disease requiring dialysis, and non-traumatic lower limb amputations. The burden of this cellular damage is shifting much earlier in the human lifespan.
For you listening, this is exactly why we wanted to trace this entire journey. From the stark history of the pre-insulin era to the biological bouncers on the cell doors, down into the mitochondria to meet the four horsemen of damage, all the way out to the compounding dangers of the diabetic foot. Understanding the mechanics of the silent water damage is your best defense against it. But before we wrap up, there is one final, almost haunting concept buried in our sources that builds on everything we've discussed.
Yes. The phenomenon known as the legacy effect, or sometimes referred to as metabolic memory.
It sounds like something out of a sci-fi novel.
It does. It was first vividly observed in a landmark Danish study called STENO2, and in the long-term follow-ups to the DCCT trial. Researchers discovered that even after a strict clinical trial ends, or even if a patient manages to get their blood sugar under absolute perfect control today, the years of poor control from their past still echo forward.
Wait, so the cells actually remember?
Yes, the cells literally possess a biochemical memory of the high glucose environment.
So the damage continues to unfold even after the sugar levels are completely normalized.
Unbelievably, yes. The prior years of the glucose flood leave a permanent structural and epigenetic imprint on the blood vessels. This imprint outlasts the excess sugar itself, continuing to drive low-grade inflammation and vascular stiffness.
Wow.
It means metabolic health isn't just a daily checklist where you get to wipe the slate perfectly clean every single morning. It is cumulative.
It's lifelong. It is essentially epigenetic karma. The way you treat your cells today, the fuel you force those broken turnstiles to process, will physically dictate how those cells behave a decade from now. You can fix the leak, but you still have to deal with the rot in the drywall. That is a profound thought to leave on. Thank you so much for joining us on this deep dive. We hope this changed the way you look at a simple sugar molecule, and we will catch you on the next one.